Good afternoon, everyone. My name is Gavin McDonough, and I'm happy to welcome you to this Thursday's webinar. Our co-coordinator, Beatrice Gubis, will happy to be introducing our speaker today and the webinar. Thank you, everyone, for joining, and thank you for your patience. Beatrice, the floor is all yours.
Thank you, Gavin. So we have the pleasure to welcome Professor Mariane de Montalembert. Professor de Montalembert is a pediatrician. She's working in Paris in Necker-Enfants Malades, but also she is related to the Universite Cité, Paris Cité, and also the Laboratory of Excellence, GRX, also in Paris. She has been involved in the patient association, in her patient, of course, but also to working with general practitioners. But nevertheless, she has also been involved in really innovative therapies. And today she accepted to speak with us about gene therapy, but her viewpoint as a specialist in pediatric hemoglobin disorders. So Professor de Montalembert, thank you very much for taking this topic.
Thank you very much, Beatrice. So I will open my screen and you tell me if that's okay for you.
Almost. Yeah.
Okay, so.
Very good, thank you.
So thank you. As said Professor Gulbis, I am a pediatrician and not a transplanter. And I will discuss with you the point of view of a pediatric hematologist, not a transplanter, and thank you to offering me this opportunity. These are my disclosures. All of you know that life in sickle cell disease may be really difficult, even if there is a great variability in the clinical expression of the disease. Variability depending on patients, and for each patient depending on periods of life, but in most cases a heavy burden. As you can see here, when you look at the quality of life of sickle cell disease patient versus the US general population, or the life expectancy, 50 years in US, with comparison to 80 years in the general population. One point is that there is no early prognosis factor, and we cannot predict which children will have the most severe forms. We cannot predict early. Most complications, once established, are irreversible and sure. Pain remains an unmet need. All these issues make that curative treatments are really needed. Talking about cure, we have been able to perform HLA identical sibling hematopoietic stem cell transplant now for 40 years. Results are good in sickle cell disease, as shown here in this diagram. The cases are gathered by Eliane Gluckman, 1,000 bone marrow transplants. Overall survival 93%, event-free survival 92%. Main concerns are graft versus host disease. Acute GVHD 20% and chronic GVHD 10%. Out of those 10%, 2% of extensive chronic GVHD. There are the possibilities of complication of immunosuppressive drugs used to prevent or treat GVHD, and of course the risk of transplant graft rejection. Altogether, these are good results, and hence, having an HLA identical sibling is today an exclusion criteria for gene therapy. But in fact, the probability to find an HLA-matched sibling donor for patients with sickle cell disease is not very high, estimated at 18%. Then you can try to find a matched unrelated donor, but first, the probability of finding an unrelated donor in the US registry is not better, 16%, and the results are not good at all. This publication was published 9 years ago, but I didn't find any more recent publication. And in unrelated donor, the incidence of chronic GVHD was 62%, with 38% of extensive form. And the authors concluded that they were not going to go on with this protocol. After, you can move to haploidentical hematopoietic stem cell transplant. Not so much limited by presence of anti-HLA antibodies, but here are the results as published past year by Kassim. The team used the Johns Hopkins protocol, adding tiotepa and post-transplant cyclophosphamide to prevent GVH. 70 patients, median age 19, 11% of graft rejection, 7% of mortality, all related to infection. Moderate severe chronic GVH 10%. And when we look at the diagram, it is very striking that all rejection occurred in children. 8 rejection, 8 children. Then Kassim tried to improve this protocol, and he added in preconditioning hydroxyurea. The point is that at high dosage, 30 milligrams per kilo per day, only 1/3 of participants tolerated this high dosage. The 2-year event-free survival rate was 88%. And most of all, there is a high rate of chronic GVH, 22%, with 14% of moderate to severe. Hence, results are promising, but not so good. Then, what is existing? Gene therapy. Gene therapy involves autologous transplantation of genetically modified hematopoietic stem cells. This genetic modification can either cure a disease permanently or improve its symptoms. But the number of patients treated for sickle cell disease is still limited, with relatively little experience, and numerous trials are underway. I have taken this slide from a nice cartoon made by Stefano Rivella in a paper we published this year. Here we are talking about ex vivo gene therapy, because today we have no access to in vivo. First, we harvest the cells. Then you proceed to gene therapy. Either you add a therapeutic gene or you perform gene editing. This technique was the first one which has given good results some years ago. It was the publication with Marina Cavazzana. It was 10 years ago. It was my patient. And this patient was severe, and he had the addition of a therapeutic hemoglobin, AB8087Q, which was within the HBS molecules, decreasing the probability of sickling. It is developed now by Bluebird. Then you have the technique developed by Vertex, which is gene editing with as target BCL11A enhancer. You use electroporation. And in fact, the problem is that there is a creation of double-stranded DNA breaks. Hence, the tool, the aim is not to have those double-strand DNA breaks using base editing. Look at more deeply the process. First, you have to harvest the cells, but it is not so easy to harvest the cells. And it is more difficult for sickle cell disease patients than for thalassemia patients. And as patients are getting older with more inflammation, it's more and more difficult to have enough cells. Then you make the manufacturing of the cells, of the stem cells. we have said either addition or editing. It takes around 6 months. Then you have to perform myeloablative conditioning. You perform myeloablative conditioning, you have the cells back, then you infuse the patient, and then you wait for recovery, which may be rather long. Here, summary of the clinical trials. This is a family of gene addition, and it is Bluebird results. Gene addition of ABAT87Q. 47 patients infused, median age 23, median follow-up 3 years. Results were good, with more than 80% of cells having more than 40% of therapeutic hemoglobin. We will see the reduction of pain. It was approved by FDA. What about Vertex? CRISPR-Cas9 editing of BCL11A erythroid-specific enhancer. 46 patients infused, median age 22, median hemoglobin level increased, and reduction of pain approved by FDA. We are not going to develop those techniques, which are with less results. Again, age. For Bluebird, 12 to 50. For Vertex, 12 to 35. All genotypes but HBSC. Definition of pain as inclusion criteria is not exactly the same. What is the most important is that Bluebird accepted a past history of stroke, while Vertex didn't. Exclusion criteria, history of abnormal transcranial Doppler, Moya, and so on. About pain, these are results presented at the ASH in this past December. Around 40 valuable patients. Almost all patients are better, but 11 still are painful. Most of the painful patients were those who were previously highly painful. When you were before gene therapy highly painful, you may still be painful after gene therapy, but less. They have a real dramatic decrease in pain rate, but they are not totally free of pain. About Vertex, same results. 42 evaluable patients, 37 no more pain at all, but for some of them, still painful after, when they were highly painful before. So an improvement of severe pain, but not totally free of pain. There are many uncertainties, in fact. Is it a cure? We remember that patients having undergone gene therapy, they have still around 50% or even a little more of HBS, the other hemoglobin between therapeutic hemoglobin or fetal hemoglobin. It is not a cure. What will be the impact on organ damages? We don't know at all. We do not know really at all. What will be the duration of the benefits? We don't know. We know that there is a safety issue, and busulfan toxicity may be a problem. In the thalassemia trial, there was one death in a thalassemic child. He died from a toxicity of busulfan. There are concerns about induced leukemias. In the Bluebird trial, there were 2 leukemias observed, which were analyzed as not being related to the procedure of gene therapy by itself. But we are making integration of transgene. We are fearing clonal hematopoiesis and leukemia. Some mothers, they tell me, I don't want any hematopoietic stem cell transplant. I prefer gene therapy because of the concerns about fertility. But in fact, it is exactly a myeloablative protocol. So the risk on fertility are real. About females, we have data from hematopoietic stem cell transplant. And I found nothing more recent, but perhaps you have some more data, than this publication in 2016. And combining 80 cases from 4 fertility centers, the pregnancy rate was 25%, thanks to the cryopreservation of ovarian tissue. 25%, it's not 100%, it's better than nothing, but it's 25%. For males, as in hematopoietic stem cell transplant, we are performing in children cryopreservation of testis tissue. We absolutely do not know whether children will be able to be conceived with this testis tissue. But for adults, of course, we can do cryopreservation of sperm. There are a lot of challenges. Some patients, the companies are always giving the results of the patients who have received the infusion, but many patients are receive the stimulation, and there is no possibility of mobilization of enough stem cells. So mobilization is sometimes not possible. And manufacturing induces a very significant loss of viable cells. But progress are very, very fast. And I just would like to mention this base editing technique, which has been presented at ASH and 1 month ago at EHA. With fewer cycles for mobilization, high dose of viable cells, short recovery from aplasia, and high fetal hemoglobin percentage. So this is the Beacon study presented at EHA. It is a base editing, meaning that there is no double-stranded DNA breaks, a better safety, target HBG12 genes. Adults, 18-35 years, same inclusion criteria, but what you see is that 2/3 of patients required only 1 mobilization cycle and a few more. A very high dosages of viable CD34 cell per kilogram, and a very rapid engraftment. So, very promising technique. And FDA gave the orphan drug designation, meaning that they will have more opportunity to develop quickly the drug, the gene therapy. So, I have seen preparing those presentations, this publication. It is a testimony of a mother. As a mother of 11-year-old twins born with sickle cell disease, she explains that her daughter had a bone marrow transplant at age 10, but the boy had no donor. The unfairness of the situation was overwhelming. When Casgevy was licensed, it was the first time I felt optimistic for both my children. The hope that they might one day live without the constant fear of a crisis is astounding. However, the question remains, will we be able to access the treatment when my son becomes eligible at age 12? And will the NHS have the necessary infrastructure to support families like ours? I do not think that the cost is the bottleneck, because when you look at the cost of sickle cell disease in non-elderly adults, on a lifetime period, it's $2 million. Finally, the cost of gene therapy, which is around $2-3 million, is not so much higher. So I do not think the bottleneck will be the cost. But there is a problem for the need for specialized teams capable of carrying out collection, infusion, post-infusion period, which may be the problem. And it was illustrated at the ASH meeting by Payal Desai. She said, okay, US centers are able to perform bone marrow transplant, but looking at what has been done for Bluebird, Lyfgenia, and for Vertex Casgevy, we can't think that large centers may be able to treat up to 10 patients a year. 10 patients a year. In the United States, there are 100,000 patients, and they are able to treat 10 patients a year. So sure, there is a need for selecting patients. So here we move to a paper we wrote with Lucia De Franceschi and with a team you will see, coming from EHA and from EBMT. First, you need to be HBSS and HBSC beta plus beta 0. So we exclude HBSC. Having an HLA match family donor in the exclusion criteria. And here we just reproduce what is in the regulation authority documents, older than 12. So we were two groups, EHA Specialized Working Group and EBMT Hemoglobinopathy Working Consensus Conference working together. Inclusion criteria, we had a lot of discussion concerning HBS beta plus. And they were authorized by Bluebird and Vertex. We defined them as patients with frequent or severe complications of sickle cell disease, HbA less than 30% and HbF low. We considered that patients who had baseline fetal hemoglobin at 30% or more were not good indication because moving from 30 to 40%, we thought it would not change totally the outcome. No donor. And that is important. Very often patients they say, I want to get rid of the disease, I want to be free. Yes, but they have to agree to annual controls monitoring as long as requested by health authorities 15 years. It's not totally to be free, having control every year up to 15 years. Appropriate documentation of patients' medical history, and we have proposed to open the window to treat patients above the age of 2 years when additional data and longer follow-up will become available. And we thought that it would not be safe to perform gene therapy in patients older than 45 years because of lack of data in this patient age range. So it is a heavy table, but it is simple finally. Regulatory agencies, they include patients with vaso-occlusive crisis and acute chest syndrome. We propose to open. In age, we have said that, but we propose to accept organ damages, but moderate organ damages with no risk during the conditioning period, meaning that they may have made acute chest syndrome, it is accepted. So heart, diastolic dysfunction, but no restrictive myocardiopathy. Pulmonary hypertension, but not severe pulmonary hypertension. Liver disease, but without hepatic failure. Moderate chronic disease. Persistently abnormal transcranial Doppler velocities despite hydroxyurea at maximum tolerated dose. And significant cerebrovascular disease, but no moya-moya. Again, more indications should be considered, including cerebral vasculopathy, given that the organ damage must not be severe to be able to tolerate myeloablation, and given that we have to clearly explain to potential candidates that the impact of these treatments, especially on cerebral vasculopathy, is not known. So, short follow-up, pain, transfusion, recovery from aplasia, immune reconstitution. I don't know when Vertex is going to give the results, but I had the opportunity to see these results, which are very good concerning immune reconstitution. Then, of course, organ damages and hematologic data and integration site analysis. And then up to 15 years follow-up just to see that there is no occurrence of any hematologic malignancy. And I think it is my last slide, and I will be happy to answer your questions.
Thank you very much. So if there are no questions until now, I have a first question. Why did you exclude or not include other severe sickle cell syndrome like HBS and D Punjab or S and O Arab?
You're right, Beatrice. I think that they would be accepted. In fact, you are totally right. If I deeply think that if someone with S.O. Arab or SD Punjab comes, it is considered as a very severe genotype and we would accept it. The question was about HBSC. And it is a very hot topic. We have steering committee in Vertex. We discuss it every time. So far, given that we have a huge pressure to include patients, surely HBSC won't be a priority. It is possible that patients with HBSC are severe, but it's quite more rare than HBSS and HS beta 0. No, you're right, for HBS O Arab and D Punjab, I think they would be accepted without any problem.
With your knowledge related to the evolution of organ damages, do you think that at the end, with the different gene therapies, there could be different indications?
In fact, we are in a period we do not know, we know nothing because we do not know the consequences of haploidentical bone marrow transplant on chronic organ damage. We think that they could improve chronic organ damages. I don't know. I don't know whether having permanently HbF at 40% will improve the risk of chronic organ damage. I suppose yes, but honestly, I don't know.
And there is another question. So thank you for your presentation. Given the absence of evidence of the effect of gene editing on cerebrovascular risk in these patients, which are instead available for hematopoietic stem cell transplantation, would you offer gene therapy to a patient with previous stroke, or would haploidentical be a safer option?
Well, this is a quite excellent question, and I think that there is no correct answer. But as to my experience, what we see with the haploidentical bone marrow transplant in children are not so good results, with 25% of rejection and with still a higher rate of the risk of chronic GVHD, 22% with 11% of moderate to severe, is not so good. So I think if it was a child, if I had the choice, I would use really gene therapy. If it is an adult, I don't know. And I think that this excellent question, only time will help us to answer. But it is really the heart of the problem. Really, I would make a difference for children. I would not, in our institution, we are very reluctant to perform haplo in children. In any case, if the vasculopathy is very severe, nothing will work, in fact, because the brain damages are already settled.
So regarding fertility, of course, in vitro fecundation is also not 100% results of having a baby. And of course, with those patients, most of them will have to go also to pre-implantation, I guess. So I was wondering if if I remember well, it was 25%.
Yes, but perhaps you have newer data. For me,
Okay.
I will look for that, but there are not so many, in fact, reliable data. What we say, we never give percentages to people. We say that there is a risk of on the fertility.
Okay.
But in Europe, we are rather lucky because I think that the cost of preservation of fertility is not at all on the at the charge of patients. I'm not sure that it will be the case for gene therapy in United States, but I'm not sure that it is totally taken in charge in the United States for hematopoietic stem cell transplant. I'm not sure of that, but clearly it in the mind of people performing gene therapy, it is mandatory to offer cryopreservation of fertility to people going through the procedure.
Okay, thank you very much. Are there any other questions or comments? Don't be shy. So thank you for this comprehensive overview. As you nicely showed, the capacity to offer GT is limited. In young adults, we could treat more patients with haplo identical. Oh là, ça bouge.
With the same resources, yes.
Yeah, you can see it? Okay.
Yes,
with
I
the
see.
same resources, is this a reasonable option to increase the number of treated patients with sickle cell disease?
No, it is a very, merci. Catherine Lambert, I say merci. So it is a very frequent question. I totally understand it because the cost of haplo is quite less than the cost of gene therapy. But I do not know exactly the cost of chronic GVHD, honestly.
So you see the next question
No,
about...
I'm thinking sorry about it.
Yeah, excuse me.
I think that if you have a patient with haplo, with a rejection or gene therapy or with infection troubles, it may have a cost as well, costs which are not to be feared in case of gene therapy. As well in haplo, you will have the risk of mixed chimerism and most possibly of leukomogenic events. So all these remarks are excellent, but times will tell us the answer, really. But honestly, if I have a 10 years old child, I will propose him rather gene therapy than haplo, really. If I have a 30 years old patient, I don't know. I don't know. So next question. Given that the gene therapy trials excluded patients with above 15%, how can we be confident that it'll work in patients constantly taking it? Thank you for the question. Thank you. Really, thank you.
We encourage them as we do in the regular follow-up. Huh?
Yes, I don't know. I don't know. It was a question when this paper was published. One of the remarks of the reviewers was, do you consider to offer gene therapy to someone who is simply not compliant to hydroxyurea? It was a very good question, and I answered yes, because whatever the cause, at the end, you have a painful patient. So indeed, whatever the compliance to the drug, I think that if they do not take the drug, really you cannot adapt your indication on the compliance to treatment. But really, these are excellent questions. It's very difficult to make any presentation on gene therapy because if you are honest, there are quite more things you do not know than things you do know. And I think that this presentation was, I told you our uncertainties. What is difficult and why I'm rather happy not to be a transplanter is that I tell you what we do not know. But when I was in a recent meeting, international meeting, there was a presentation on gene therapy and no limitation was given. And I think that it's not very fair not to give the limitation.
So, no more questions?
A nice and simple question will be welcomed. But nice, simple, with easy answer, which
It's the end of the afternoon, yeah. No,
so
but it's important to discuss, so we have,
questions,
yeah.
but not easy ones.
Yeah,
Because
but we have different point of view.
I know, but everything you are asking me is totally exact and correct. So I don't know.
But this is also important to know that we don't know everything. Okay. So if no more question, I really thank you very much. And also all the audience. Yeah, that's from Gavin. And of course, I
Merci.
say good afternoon. Merci beaucoup,
So
Mariane.
sorry, Catherine Lambert, where are you working? Because I think it's in France. I don't know. Bah oui. Ah si. Ah, Bruxelles, so you're...
Oui, bien sûr. Je l'ai laissé répondre, mais...
Je ne pas le micro. Je travaille à Bruxelles et on s'est déjà rencontrés. Je vous avais invité pour donner une conférence il y a une dizaine d'années pour l'association de patients qui
Ah,
était...
je me souviens très bien.
Voilà.
Ah, je me souviens très, très, très bien. Mais c'était sur le... It was on genetic counseling, no?
Yes, it was.
Genetic counseling, yeah. Yes, I remember, yeah. But for instance, sorry to go on. I remember that one guy, you must remember, he said, well, I'm totally relieved with the hematopoietic stem cell transplant. I'm totally happy. My only concern is that now I have problems to be a father for fatherhood, but I don't know why, but sure, it will be better after. And I was thinking that he had not understood that he had a myeloablative conditioning. You remember the story?
I remember, and I think that the transplant in children is totally different as for young adults. So it's something that is integrated in their journey. Also, a small comment, but I think that we have to be very clear with our patients because about reproductive issues that they are still able to transmit the disease, whatever the cure. And so I think in sickle cell patients, well, I also treat hemophilia patients who had gene therapy. So they are still a carrier for the genetic disease. And so it's important to remember them when they grow up,
Right.
that their children also may be affected if we don't screen and provide a good reproductive information.
I totally agree.
But I'm happy to see you again.
I'm ready to be invited in Brussels, Beatrice, no problem.
Okay. You're welcome.
Yeah, you're always welcome. So now it's the end, I think. Finally, yes. So thank you very much to all of you, the audience and Professor de Montalembert. So have a nice evening and summertime.
Thank you very much.